Hi, Nicole.
Hi.
How's it going?
It's going well. How are you?
Oh, just trying to get my head together. Get your head in the game, as they say.
You know, your head's in the game. I can't see your head, but I'm sure it's in the game.
All right. That's because like right now, Nicole, I'm literally trying to get my head in the game. I was like, maybe I should do something with my face since I don't do that much these days and just put on, like a drop of makeup. Maybe that's a good idea. Maybe. They say that when you're not feeling so great, sometimes trying to make yourself feel better through your appearance or something is supposed to lift your spirits, whoever they is.
I call it my bad bitch lipstick.
Yes.
When I need that little assistance.
I love it. I love it. And maybe just because you said that, I'm going to put some lipstick on. That wasn't a part of the plan, but
Anytime I can help inspire for a lipstick, I'm here for it.
I love it. I love it. Are you like Christina? She has like literally 1,000 lipsticks and nail polish colors. It's interesting.
I'm more of a lipstick type of girl, but I don't have a million different colors. I have my standards that I invest in.
Okay, gotcha. Laura, perfect time to enter.
Yeah, I know Laura's still connecting to audio.
Okay, so maybe she missed our whole lipstick conversation.
Is there anyone else that's on a panel for this that you'd like me to add or enter in to the room? Okay.
Nope, this one's a really light lift. Thank you for hosting and doing this both days. It's been a lot less stressful than I thought.
Oh, good. Teamwork makes the dream work. So I'm here to.
It's totally seamless.
I'm here to offer my Zoom license whenever.
So Nicole, at the end of the day, we had like 485 people register.
Oh, wow.
So I definitely was like sweating it yesterday. I was like, oh no, this is gonna be so bad. Tell me, Nicole, how have you been feeling about this event today?
Oh, I'm really enjoying the event. As a Floridian, there's a lot to talk about as far as the bad. But also understanding that they did what they did.
Yeah.
And unfortunately, sometimes you have to make sacrifices to even be able to perform a service.
Mm-hmm. Yeah, I mean, Hansel is, he made the concessions he made. He had a long-term game plan for it. He has a lot of guilt about it. He talks about it all the time. And unfortunately, I mean, most SSP legislation that comes up has some really pretty severe concessions. And some of them are scary. Hi, everyone. We'll just wait for a few minutes for folks to filter in. Exciting to see so many folks from the session before. And we'll get together. Anna. Okay. Just try to mute everybody. I hope that Paulette, you can still talk, Greg?
Yes. Can you hear me?
Yes. Great. Cool. Just trying to deal with as much tech as possible. Okay. All right, so it looks like we're holding steady, or steadier anyway, so I guess we'll go ahead and get started. So thanks so much, everyone, for making space in these 2 afternoons of this very exciting meeting that I've I've been thoroughly enjoying, so, and not stressed out about. So I think that that's got to be a sign that the content has been good, and just really appreciate everyone's effort to support syringe access in the South. I am really excited for this session here today. I am joined by my colleague and friend, Hollet, who is working over here at NASTAD with us on the healthcare access team. I'll let her actually introduce herself. Again, my name is Laura Pegram. I'm the Associate Director of Drug User Health over here. And yeah, just excited to kind of bring this conversation to SSP, the Southern SSP Institute. This is the first time that we've really incorporated some of our work around trauma-informed approaches and drug use and health systems, and really just having a nice conversation around how nice, I don't know if that's the right descriptor for about trauma, but a conversation around how we can improve our programming with people who use drugs, and really reduce some of the harms that might be embedded in our work. Yeah, so excited to be joined here with Mahalet, who is really the person who knows all things about trauma. So I'll go ahead and pass it over to her and let her introduce herself, and we can get going.
Thanks, Laura. No pressure, right? Good afternoon or good morning, depending on where you all are joining us from today. As Laura mentioned, my name is Mahalet Kabeta. I am a senior manager on the healthcare access team at NASTAD. Just a little bit about what I do. I lead our trauma-informed approaches portfolio of work at NASTAD, and a majority of my time is really spent supporting Brian White HIV/AIDS program Part Bs and ADAPs, and just they're running the day-to-day operations of a Part B and ADAP program. So I will leave it at that for time's sake, but really excited to discuss trauma-informed approaches to the work that we're doing. Laura, I'm with you on the somehow trying to find a balance of saying that we're excited about this is always a little awkward. I think I am excited for us to have a very necessary conversation that relates to us accomplishing the ultimate outcomes that I think we all want in this work, right? Which is to provide kind and compassionate services and care to people who are living with HIV, hepatitis, or folks who are using drugs. So I'll leave it at that for now. Thanks. So just to sort of set the stage, triggers are, they're interesting. There's not a uniform trigger for folks. Just hearing the word trauma can be triggering for folks. So I want to name that because that's a lot of the feedback that we've received as we do this work. And so it's a bit challenging to tell what exactly might be triggering throughout this presentation, but the point of discussion is trauma, right? So we want to first provide a blanket content warning that this is a session about trauma. When I discuss a specific incident of trauma, I will also provide an on-the-spot trigger warning so that folks can choose to step away, to mute us, whatever feels best to them. But we also just want to say in general, if this conversation gets to be a lot, if the session gets to be a lot, we really want to encourage you all to take care of yourselves and step away and do what works best for you, whatever that is. I believe these sessions are being recorded, so if you would like to circle back at a later time when you feel better about listening, you also should have that option available to you. All right, so a little bit about what we'll be covering during this session. We're hoping that the session leads to a better understanding of harm reduction as a trauma-informed approach that is related to HIV, hepatitis, and drug use, both prevention services, care and treatment services, and the like. We're also hoping that you all can walk away with the ability to describe methods to mitigate trauma within the services that you all provide. And finally, we also are aiming for this to improve the service delivery approaches that you all take, and reaching people who use drugs more effectively, specifically when it comes to avoiding triggering folks or re-traumatizing them. So let's start off with just ensuring that when we use these terms, we're all talking about the same things, right? So a shared understanding is really important. So firstly, trauma, there are many definitions. This is just the one that NASTAD is operating with. You know, I encourage you all to just read it for yourselves. And just be mindful that we don't feel like any one definition of trauma is more right than the other one. This is just what we are operating with. So I'll give you a moment to read over that. Okay, and trauma-informed. Trauma-informed is what we want your divisions, right? If you're at the health department, your divisions or your bureaus, or if you're at an SSP, what we want for your agency to be, right? It's an approach to administering services in the work that we do that acknowledges that trauma can be active in a person's life, or they could have experienced it in the past, and that those traumas are manifesting in many ways, right? They can be physical manifestations, mental manifestations, or behavioral. And then finally, TIC stands for trauma-informed care, and TIA stands for trauma-informed approaches. So we try to be a bit intentional about using trauma-informed approaches as much as possible, unless we are talking about a very specific clinical setting, right, or a care or treatment setting, because we want folks to think broadly about what we can be doing to mitigate and prevent trauma or re-traumatization from occurring in the services that we provide, or with the services that we provide. And so we try to be intentional about saying approaches, because again, it's not just about care. It can be about the policies and practices of your agencies. It can be about how you all as individuals, right, who are implementing these services approach the work that you do. And so that delineation is important to us to make. Next.
So can I pause for just a second? I just want to make sure that we are screen sharing. We just got something from someone who says they can't see the slide. I think that you just want to troubleshoot here for just a sec. So I think that if you're seeing just the facilitator, you might want to toggle to the upper right-hand corner of the Zoom thing and go view. You might be on a speaker view only, if that makes sense. Okay, I would say go ahead.
Okay, sure. Thanks for troubleshooting, Laura. Thank you. So I'm not sure if anyone has heard of neuroscience before. So this is a relatively new field of study. Providers are developing a more comprehensive understanding of trauma, including through the concept of neuroscience. And NEUR is actually an acronym for neurobiology, epigenetics, adverse childhood experiences, and resilience. And we're going to talk through each of them, so don't feel like you have to rush to jot those down. But what neuroscience does is provide a holistic understanding of how trauma impacts health outcomes and what hope there is, right? That's the resilience piece for us mitigating and supporting our clients in coping with the trauma they've experienced. And so we're going to start off with the N, neurobiology. Now, neurobiology, there's a lot that can go into neurobiology. Because we are discussing trauma today, though, I'm going to focus on the 3 parts of the brain that are most important to our understanding of trauma. So first is the prefrontal cortex. It is also known as the thinking center of the brain, and it's located near the top of your head. So if you touch your forehead, it's right behind that area. When this area of the brain is strong, we're able to think clearly, we're able to make good decisions and be aware of ourselves and of others. Now, research indicates that after trauma, particularly during childhood trauma, the prefrontal cortex experiences a loss of neuronal integrity. And that's just a fancy way of saying that it's less able to communicate with other parts of the brain because it has been compromised, right? That's the loss of integrity. Now, next, if we move along to the hippocampus, which again, if you were to put your hand, or your finger on your forehead and you were to go just like a little bit deeper inside, that's where the hippocampus is. And the hippocampus is known as the emotion regulation center. When this region of the brain is strong, we're able to manage difficult thoughts and emotions and recall and recognize memories. So for example, when the smell of a perfume reminds you of your grandmother, that is likely your hippocampus that is in action. In contrast, for individuals who have experienced traumatic stress, they may experience vivid memories or persistent thoughts that are reminiscent of a trauma. And so for those folks, what might happen is they might be having a difficult time distinguishing between a memory, right, a thing of the past, and a current threat. And we're going to talk through an example in just a moment that will tie the prefrontal cortex, hippocampus, and amygdala and how they kind of work together in a not so helpful way for folks who have experienced trauma in just a moment. Before I go into that, though, I'm going to explain the last part of the brain, right? The amygdala, or the last part of the brain that's relative to our conversation. And that is known as the fear center. So the fear center responds to stress and anxiety, and it coordinates a behavioral response that helps to ensure survival. So if anyone here has ever heard of a fight, flight, or freeze response, right? That is your amygdala that is at work when eliciting those responses. A very simple example, I'm not going to get into the big one yet. A simple example, you're walking down a hiking trail, suddenly you see a snake, and with lightning speed, your amygdala reacts to that snake. Before you even consciously notice, hey, there's something dangerous, your feet are already turning you around in the opposite direction and you're running. If you're afraid of snakes, like I am. Perhaps for some of you, that would not happen. So the amygdala helps you react quickly when there is a threat in the forest, but it can be a problem for someone who's experienced trauma, right? So in the traumatized brain, the amygdala is constantly on high alert, and it often leads to what may be deemed or seen as inappropriate, erratic, or defiant behavior, as that part of the brain is unable to access the prefrontal cortex and apply logic to the situation, right? Because remember earlier when we started off, the prefrontal cortex has lost neuronal integrity. So it's not communicating well with these other parts of the brain. So now I'm going to give you all an example. It's going to take me about 1 to 2 minutes. So for those of you who childhood abuse is a trigger for you, I invite you all to mute me for the next 2 minutes while I describe this example. So please, content warning, the triggers are our childhood abuse. So I'm going to give you all about 2 seconds to mute. Okay. So the example I want to share with you all, I know this can be tough for some folks, but I feel is really important so that we can relate it to what you all might experience on a day-to-day. So when, let's say we have a client who, as a child, was abused by their grandmother. So tying this into what we just spoke about a few minutes ago. So their grandmother used to wear a very specific perfume, right? And so they're thinking of the physical abuse that they experienced by their grandmother as a child, right? When they smell that perfume, that is a trigger for that person. So now this person walks into your SSP office, right? Or they come into your clinic, let's say your HIV services clinic, and they sit next to a person who is wearing that perfume, right? And so at this point, this person can start feeling triggered. What you see is, and let me be specific because the emotion regulation center is important to this. Now they smell that and they're not able to discern. Remember, their hippocampus has been compromised. So they're not able to recall and recognize memories as a thing that happened in the past. It feels present to this person. So their behavior starts changing, right? Their amygdala, because they smell that scent and they smell that perfume and they're going into their fight, flight, or freeze response. Perhaps for this person, their response is fight, right? And so they start becoming visibly agitated. Perhaps they're expressing to whoever is working at the front desk, right? Your administrative assistant or receptionist. They're frustrated, they're taking too long, they've been waiting here forever, and they begin to raise their voice. Maybe even physically, you know, you're seeing movement that to you seems like a threat to your safety as staff or to the other clients that are in the room. And so we see how the amygdala, hippocampus, and prefrontal cortex can kind of, what is the word I'm looking for? They can kind of come together to in a way, sabotage almost the experience or the behaviors of people who have experienced trauma. And so I hope that, I really hope that wasn't triggering A to folks. B, I hope that that helps for you all to kind of demystify some of the behaviors you might be seeing in your clients. So I'm gonna move ahead and move on to, I'm sorry, could we go back one slide to the, thank you, to the A in NEAR, and that is adverse childhood experiences. So the original ACE study was conducted at Kaiser Permanente in partnership with the CDC back from 95 to 97. Over 17,000 people that were receiving physical exams, and these were adults. They also completed confidential surveys regarding their childhood experiences and their current health status and behaviors. And the survey included questions that fall into the categories you're seeing on your screen around abuse, neglect, and household dysfunction. In order to avoid triggers, I am not going to talk about what those questions were. Now, what happened is that what they learned through the study is that childhood experiences, both positive and negative, have a tremendous impact on future violence, victimization, or survivorship is a more positive term, and perpetration, as well as lifelong health and opportunity. And that's what you're seeing on the bottom, right? So what they noticed, this correlation was the more adverse childhood experiences or childhood trauma experienced by a person, right? That's their ACEs score across the bottom from 0 to 4+ ACEs, the more likely they were to either have an experience of violence or to perpetrate violence. Now, can we move to the next slide?
And if I can just chime in for just a second here, because ACEs is so important to understand in terms of, you know, sort of how our brain, you know, becomes what it is and how it, you know, kind of it gets shaped. We're going to talk about it more in depth soon. But, you know, sort of the counter to so much about trauma-informed approaches is really about resilience too. And so sometimes ACEs, when we're talking about drug use in particular, can feel a little shaming, a little judgmental, and that is not the intention of that study, you know, even a little bit, or the findings of it. Really, you know, I don't want anyone to, sometimes I hear folks in programs in particular say, you know, or, you know, parents who were using substances when their kids were young, that sort of thing, carrying a lot of weight and guilt around that. And my hope today is that we can have this conversation just about the incredible resilience of the brain, right? And that there's no one-way street here in terms of impact for children. And so it's an important thing that will run throughout this conversation.
Absolutely. Thank you, Laura, for bringing that up. And we're going to be talking about resilience in just a moment. So epigenetics. Epigenetics is the E in neuroscience. And what you're seeing on the left side, right, that pyramid is actually the conceptual framework of adverse childhood experiences, or ACEs. And what you're seeing on the right, that pyramid is, if we were to take the conceptual framework of ACEs and we were to layer on top of that epigenetics considerations, right? And so Epigenetics, what it is the study of changes in organisms caused by a modification of gene expression rather than altering the genetic code itself. So that is a very scientific way of saying that when folks reproduce, right, that the genes of the parents, right, are not changing, right? So the gene itself is not changing when a child, right, when a fetus is created. However, what is happening is that our bodies are reading the genetic code and altering that part, right? So the coding is what's becoming altered. And the reason this is important is that we need to understand that a person's health is not just determined by the parents, right? But by historically whatever those parents are carrying with them. This is important when we talk about considerations around racism, right? And so when we think about the historical impact of slavery in the United States, I mean, slavery happened to other places as well, but we're in the US right now. So using that as an example, what that can do to determine a person's trajectory, health trajectory, life trajectory, just the impact that it could have. And this is when it's also important to reiterate what Laura said. These things that we're discussing, yes, they are the kind of negative sides of this, but resilience, right, is the hope, the hopeful side of neuroscience. And so next slide, please. When we put all of these things together, right, the ACEs and the epigenetics, this is what we get. This is the pyramid that we get. And this is actually, again, another conceptual framework that's available from CDC. And what it shows, right, is before we can even get to a point where we're considering potential childhood trauma, we first have to take into account the social conditions that a person is born into, right, that a child is born into. And then you go back even a step further is the historical trauma piece. And I should just mention really quickly, epigenetics. It's a relatively new field of study, and where the research on it actually initially began was on survivors of the Holocaust. So that's actually where our understanding of epigenetics began to be informed. And then that framework of, you know, studying that, that experience by folks is what led to studying the effects or the impacts that the historical trauma that Indigenous folks experience, Black or African-American folks experience. And so I wanted to provide that context as well. I'm going to move along now to resilience, the R. So as I said, this is like the beaming light, the beacon of hope when we discuss near science. Resilience can not only, right, the resilience existing, a high level of resilience, can not only support those individuals who have experienced trauma for that trauma to have less of an impact, but the more resilient we can support our clients, right, your clients in becoming, the better of a chance that they will have to cope in a I'm actually hesitate to say in a healthy way because there's some stigma that can be affiliated with that. But let's just say cope, period, right? Because that in and of itself is an accomplishment and something for us to celebrate, right? So this can support our clients in coping, period, in whatever ways are available to them to be able to mitigate the trauma that they're currently experiencing if they have active traumas in their life, or traumas they may have experienced in the past. Now, there's not a single set of components of resilience that is, you know, a kind of industry standard, for lack of better words. There are a lot of factors that can be protective. We've shared a few here, but I'm sure there are many more. If you have any thoughts, actually, I would love to hear from you all in the chat. I know this is not the first time many of you have heard about resilience, but any protective factors that you all are aware of have been helpful for your clients in coping with trauma. If you can share those, that would be fantastic. And I know Laura is going to talk a little bit more about this, so I'm going to move us ahead for the sake of time, I'm running way behind. I'm sorry, Laura. So we're gonna do a walk through the continuum about what can be traumatic to the folks that that we are providing services to as we work to move them right to the other side. That viral suppression is, I think, what so many of us are working towards for our clients, but getting them there in and of itself can be traumatizing. And so first, I want to talk about pre-diagnosis, right, of HIV, hepatitis, of HIV or hepatitis. So past traumatic experiences can lead to engagement and increased risk behaviors for HIV transmission, things such as sexual risk-taking or substance use. And I want to be clear here, this is not, we don't bring up substance use in a way to shame folks, right? Or to say that using substances is a bad thing. It is something that we are taking into consideration as a behavior that could potentially have an effect on our clients' health. That is what we are aiming to call out by this. And also important to keep in mind, contraction of HIV can be particularly traumatic if it is acquired during a sexual assault. Diagnosis, although treatment is widely available, the experience of receiving an HIV or hepatitis diagnosis in and of itself can be traumatic. And that's for a few reasons. Number one, the receipt of that diagnosis can be exacerbated depending on the method of delivery, right? So is this person finding out through a letter, through a phone call, through partner disclosure? Next is the person who's delivering that diagnosis. If they're not very well trained on how to not use stigmatizing language or to discriminate, that person could be causing the trauma. And then finally is the health of that person receiving the trauma, or receiving the diagnosis. So if they're already experiencing life-threatening illness, perhaps they're unsheltered, perhaps they are living in poverty, whatever this can be, like if the circumstances of that individual already has them in a high stress situation, this is only compounding and further worsening that potential trauma. Next is linkage, right? So the experience of linking to and engaging in care can be traumatic because of the invasive procedures, right, that are a part of that. Again, going back to providers who can be insensitive, the cost of care, and then the navigation of health and medication benefits, which I think as staff in this field, we probably all recognize can be hard to navigate, even as people who, you know, in our professions, we do this work. Next is retention and care. So people who've experienced trauma often have difficulty staying in care. And while some clients are at risk for falling out of care, other clients may be calling you, multiple times a day. So despite the best intention of providers, HIV medical care and support services can be re-traumatizing. Some of the reasons they fall out of care, we can think of a bunch, just a few though. Labeling behaviors that folks might be engaging in, such as sex with same-gendered individuals or drug use as immoral or bad or unhealthy, anything of the like, failing to provide culturally responsive services, and then also challenging or discounting reports of abuse or other traumatic events that that person might have experienced. And finally is viral suppression. For people who are living with HIV or hepatitis who might be engaged in care or receiving treatment, trauma is associated with a variety of poor health outcomes, including treatment adherence issues, increased viral load, and decreased CD4 counts. So I hope this helps to illustrate the areas, right, the bright spots that we need to address as the folks who are providing and creating these services. Next slide, please. And actually, for the sake of time, Laura, I think I want to hand it over to you and let you decide kind of what we want to prioritize moving forward, if that's okay.
Yeah, sure thing. And thanks for that, Mahad. I mean, it's really, you do a really great job of explaining sort of what's happening in the brain, when trauma and triggers come about. I've been like fidgeting over here, and I'm actually dealing with a very traumatized little dog and trying to keep her quiet over here. And I'll say personally, we had a little traumatic event earlier in the year, and it has really helped me understand how hard it is for her to, you know, what's happening in her brain when she gets scared by the dog next door or whatever that is, and just really, you know, appreciate that, because I am a social worker, and so I think, you know, it is really helpful when you're working on a program to even be able to communicate and message with your participants around, you know, just what is going on in the brain, and that actually helps me understand behaviors, but also often can help people understand what's going on for them too, and explain some behaviors, explain, you know, their irritability, and take off some of the stigma or the feeling, you know, self-conscious around that. So I think that that's really super helpful. And yeah, so we were hoping with this session to really kind of go into sort of that science part, and then kind of talk about harm reduction and how harm reduction is, I can't say the original trauma-informed approach, but is inherently trauma-informed in the way that it's designed, created, originated, right? That there's a lot of really intuitive logic about how these two things are deeply connected, and hopefully having a kind of conversation about some of those similarities. And then at the end, Mahalit and I are hoping to have a bigger discussion with you all and with each other around some things around systems, right? So I will run through these slides here because, you know, shifting into sort of drug use and overdose and these things, I did not put a trigger warning on this section, but feel free to obviously take care of yourselves. We will be talking about overdose, responding to overdoses, loss, and, you know, personal and collective loss and such. So I just want to warn folks there. But so SAMHSA has, you know, sort of the 4 R's of TIA, and I'll start here because I think that there's some real overlap with some of the philosophy of the SAMHSA work with harm reduction principles more generally, right? So we recognize that in order to be trauma informed, right, programs have to really understand the impact of trauma and potential paths to recovery. And this is kind of like that environmental awareness that we know good earned access programs do, right? They understand what's going on for participants as they are, you know, sort of operating and living in the environment that they do, right? That community-based knowledge is really vitally important. It recognizes, right, signs and symptoms of trauma, and, you know, really acknowledges those, right, responds to fully integrating knowledge about trauma into policies and procedures. And I think that this is a conversation that Mahalit and I have done some work in terms of offering some trainings actually for syringe access programs around responding to overdose, responding to grief, responding to loss, participant and staff care and wellness, and how to incorporate those things at a more organizational level, and also creating environments within programs to that actively resist re-traumatization, right? That actually create environments that are safe and welcoming, non-stigmatizing. Y'all see the you know, inroad here with harm reduction, right? There's a lot of alignment here. So on the next slide. Oh, can you just click lots of them? Oh, sorry, I'm bored. I'm like 6 of them. I think there are 6. Thanks. Yeah. So here's where I kind of want to, you know, for those of you who are on the line, I mean, I think that a lot of you have a pretty good background probably in harm reduction, but I want to go over the SAMHSA, the 6 principles of trauma-informed approaches. And then we're going to side by side that with harm reduction, right? And some of the philosophical underpinnings of harm reduction, right? So thinking about providing spaces, you know, that are physical, that support physical and emotional safety, right, for participants, collaboration and mutuality. You know, these are mutual aid programs, right, typically. And so we see a lot of overlap there. Trustworthiness, transparency. We know that harm reduction programs are based on the idea of building trust and meaningful relationships with participants, right? We also know that they're totally not doing harm reduction if they're not about empowering participants to make choices about their life and their health. Peer support, many programs are in fact, you know, peer-led, and best practices often are peer-led programs, right? And really, again, kind of understanding like the overall, nothing happens in a vacuum. The community influences, the social determinants that are affecting and present affecting our folks and present in our communities. So if you go to the next slide, I won't say all of those things again, but right, so the harm reduction principles, as noted by the National Harm Reduction Coalition, right, so these programs are really based on the idea that people who use drugs have a right to health and dignity in seeking that health and health care. Just dignity. Low bar here. You'd think it's a low bar. We know that programs to be effective need to be participant-centered. We know that in order to be participant-centered, they actually have to and should be ideally involving participants at many, many levels, right? They respect participants in their personal autonomy, bodily autonomy, support their choices, no matter what those choices are, because that's their body and that's their choices, right? These are very similar here. They have to be pragmatic to be effective, right? We can't just pretend to have a program that's open 1 hour a week, 9 in the morning, and say it's doing harm reduction or syringe access for people engaged in sex work. Like, that's not really a program. They have to be realistic to work, right? We have to meet people, and that's going to look a variety of ways. And again, back to that idea that nothing about drug use happens in a vacuum, right? That there are all kinds of things that are affecting why or whether or how much or how, the reasons behind why someone might use drugs, right? And so these programs, it is about working with people and about getting out that syringe and the supplies and all of those things, but it's also, these programs intuitively have an advocacy component as well, because we have to address some of these underlying social determinants that really affect access to resources for our folks, affect their potential outcome. And stigma is one of the biggest, right? And so I don't want to go on that too far, but if you go to the next slide, we also know that there are some correlations, right? I won't say causations. I think that there's an important difference there. Causations and correlations are not a thing. Like, all too often when we read studies about impacts of health or levels of drug use or percentages or likelihoods, a lot of people read in causation. And very rarely is there a clear causation. Correlations happen often, right? And we know that some of these things are real, right? That we know that if you're experienced to women who are exposed to traumatic life events, show increased risk for alcohol use disorder. Yeah. Same thing for Vietnam, like the Vietnam veterans that were studied, certainly. High incidence of alcohol use disorder coming back, and I'll come back to that one. As Mahalit mentioned, ACEs increase relapse, I don't like that word, but return to use rates for folks who are using opioids by about 20%. The impacts of abuse, have clearly impact substance use and alcohol use disorder. And PTSD is obviously leads to some correlations where we'll see some increases in terms of likelihoods. I'll say likelihoods for substance use. There's no inevitability here. I think that's one of those things, going back to that ACEs, sort of thing. Is like, there's no inevitability that just because you used substances when you were pregnant, or, you were, I was going to say fathering your child, and I was like, that's the weirdest thing you could say, parenting your child or whatever. But there's no inevitability that that is going to necessarily equal trauma, right? There's so much supportive that we can incorporate into our environment, into, really building up those skills and the resilience. It's really, really important. One thing I will say, it kind of occurred to me when we were going through these slides. So there's this great study that was done, a series of studies that were done in the late 70s, mid to late 70s. And it's called the Vietnam Studies. It was done by Lee Robbins, who's this social work researcher, social science researcher out of Missouri, the University of Missouri. No, I don't remember where. But she basically did this whole thing where she studied, there was a lot of drug use, there was a lot of opioid use and heroin use readily available in Vietnam. And many of our service members, we can say men at that point, service members, came back from Vietnam being discharged and were physically dependent on opioids. Meaning, not necessarily that they were addicted, but that they would show the physical signs of withdrawal if they did not have a steady supply of opioids, right? Or steady supply, or if they didn't have it in their body. And so Lee Robbins was like trying to kind of debunk this myth, or see if the myth was really true, that like once you're addicted, you're always. So what she did was she identified this cohort of people, many hundreds of people who were dependent on opioids, and then followed them longitudinally and interviewed them at different touch points to see if they continued using drugs, if they continued using heroin. And she found that the vast majority, over 95%, did not continue use over time. And then she asked them, how come? What's different? And they said the most logical things, right? Like, I think I might have a long life. There are not bombs going off all over. People aren't shooting at me. I have a family now. I have competing priorities, the most logical things. So when we think about drug use, and we think about drug use in the context of trauma, sometimes the drug use itself is adaptive. I know that we haven't put it on that slide in terms of like the potential protective factors, but we all have to remind ourselves, and especially when we're working with people, that not all drug use is bad. In fact, people use drugs for very real reasons, and those are good reasons, right? And it might not be forever. It might be a thing again that can change. But I just think it's really important to kind of like toss that nugget in there, is that like drugs can be very, very, very useful. So I'll pause, there. Do we want to go to the next slide?
Can I just say something really quick, Laura?
Yes, ma'am.
I've never heard you discuss that study before, but that's like so powerful for so many reasons. And one thing that keeps on coming in my mind is, we talk about social determinants of health a lot, right?
Mm.
So what I heard from that study was that their environmental, right? Environmental factors, such as bombs going off, their life being threatened, etc., that existed in Vietnam. So they were in an environment that was very high risk for harm. And then they came back into an environment, right, in the US that was not as high risk. So we changed their environmental factors, and they didn't need to cope with those environmental factors. And I think that's so powerful, because always what happens with trauma, when we see people, and this is why I always do this when I say inappropriate or erratic behavior, when I'm talking about in the neurobiology portion, the amygdala, because if you think that a bomb might go off, it is very normal and healthy for you to start running around, screaming, etc., right? And so we always blame it on the individual versus the environment that has led them to behave in that way. And so I really, wow, that was just so powerful. Thank you for sharing that. I just learned a lot myself.
Oh, good. Yeah, no, that's exactly it. And when I was talking about harm reduction as like these programs, and to meaningfully affect someone's drug use, or it is about environment, right? That there's an advocacy level and a policy level, that even if you're not directly running a program, you're working in a health department trying to support them. Like, broad public health leads to healthy communities and healthy options around health and how to maintain that, and then respect for how people do that, as in there's no one size fits all, is really vitally important, right? So important to kind of keep in mind that context, environment, mental health, all of these things are happening concurrently. I think that is, oh God, if you just walk away with just one thing today, that drug use can be really useful. And that, we'll get to that more in our conversation, I think. I don't want to get us too off track, but I think the other thing that I really want to acknowledge and note, well, there are specific ways, and a couple different ways that the community of people who use drugs and work with people who use drugs and love people who use drugs, we faced incredible loss. And I know that there, up until this last year, I mean, that felt pretty intangible for, I think, a majority of America, right? The sheer amount of loss of life in our community over the last 15, 20 years, really looking at well over, I mean, close to 1 million lives, right? And just really acknowledging that that is an incredible amount of loss. And so when we're thinking about creating trauma-informed approaches and incorporating an awareness of this at an organizational level, it's, I think, really important to recognize that there are a couple different things here, right? We are both people who are working directly with folks who use drugs, who are experiencing a lot of trauma and a lot of loss of their friends and their loved ones. And not gonna lie, we get attached to participants, right? Like, we experience loss as well, as, you get those texts or you get those just word around, losing someone in the community or even having a close scare, or even, reversing an overdose, which is it's traumatic. It really, really is. There's actually a Facebook group that I'm a part of that is like, I reversed an overdose and I'm feeling messed up. That's its title. I'm feeling it because it's a lot to take on, So there's that level, thinking about program considerations and personal loss, both for our participants and ourselves, right? But then there's also this like larger collective loss that we as a community have felt. And I think it does feel more relatable in the era of COVID. But it is really important to know that even as being part of a community of people who use drugs or work closely with that community or love that community, that is in itself a very valid form of trauma. Even if you have not been the one who's overdosed or reversed that or lost someone directly, that there is a collective sense of loss that is really, really valid and comes with some real mental health challenges and need to care for that and build up these skills around resilience. So I just want to like fully acknowledge that. And, it is very hard. It's hard work. It's good work. It's the Lord's work. It is hard work. And organizationally, there are all these things that we can do to help incorporate these concepts and awareness more broadly. But, and I think obviously there's technical assistance that we at NASTAD can provide and conversations we can have, models we can send you to that folks who have done this type of work. And yeah, just really like want to make note of those two things in particular. And I also, so those two are really delved into in this amazing guide the Massachusetts Department of Health put out a few years ago, I guess 2 years ago now, about coping with overdose fatalities within syringe access programs. And it really gives, it's a really wonderful manual that is about how to, sort of incorporate increased staff support, how to deal with an overdose on the scene, how to keep things safe, calm, secure, all of these trauma-informed concepts into syringe access program. And the link is there. We can actually put the link probably in the chat. It's a gem of a resource. And yeah, really just, yes, appreciate those folks for being so thoughtful and putting that together. So if we go to the next slide, this kind of goes back to that conversation around resilience. For those of you who have not read this book, I swear I'm not selling stuff. This book is one of the better books, best books that I've found to really give a firsthand account of sort of really reconfiguring how we think of addiction and how we think of drug use, right? Maya Solovitz is brilliant, 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 kind of scary brilliant, like intimidated in a room with her quite a bit. But she really posits that drug use, is less about a brain disease. It is more about the ways our brain has learned to adapt to things, right? If that makes sense, right? That it's more of a learning disorder, if anything, or an adaptive behavior, if anything, right? And so she says here, moreover, most people who do experience childhood trauma actually do not develop substance use disorders. Humans have a remarkable tendency towards resilience. Substance use is just one of many, many ways to cope, right? I'm just adding in things. And since coping behavior is essential to psychological survival, the coping methods learned during childhood and adolescence become deeply ingrained in the brain, right? So she's really flipping this narrative, similar to what we were talking about before, that like, not all substance use is maladaptive, and there's no inevitability here around it becoming like that's going to be the outcome if trauma is experienced, right? And I just really appreciate the way that she incorporates resilience very meaningfully and really pulls in this idea that drug use maybe isn't always the worst maladaptive behavior, right? It might just be an incredibly logical option. One of many coping strategies. Go to the next slide. Thank you. So, so much about trauma-informed approaches really does the thing that harm reduction kind of does anyway. Takes this like strengths-based approach, right? So often we have typical historic, sort of mainstream service providers who are from an old school. They see a patient or a participant, they come in and they go, okay, What's the laundry list? Like, what's wrong with you today, right? And then trauma-informed approaches kind of takes it to this next level where it's like, oh, actually, this needs to be more strength-based. Like, let's talk about how come you're presenting with this thing, right? How come you're having this challenge? How come you're having this struggle, right? And then it goes even further than that and makes it truly strengths-based and says, what's working here? There's always something working. You're alive and awake and enthusiastic. You're in front of me right now, which means something today is working, right? Something has kept you alive. Something has kept you, with enough knowledge to get here. Something is working. And I feel like that's a really important thing. I know people use that word strengths-based sort of thing, but like it's deeper than that, right? It's the idea that like there's always something that you did right, right? There's always something that's working. And that is one of the touch points for like when you're trying to work with a participant or working with a participant, to start from a place of what they're doing well. All too often we're like, oh, nope, you need to do this better, you need to do this better. In order to get housing, you're gonna have, or get a kid back, you're gonna have to have housing, that kind of thing. But like there's a whole lot that's happening in that person's life, right? And so having those, the good touch points, be able to build that trust and build that relationship and acknowledge that your priorities might not be that person's priorities, and well, they probably aren't, and that person has a lot going for them in that day. Yeah, real strengths-based. What's working here? Always something working. Can you go to the next slide? Oh yeah, we're almost done. And so
Laura,
this is just, go ahead, yeah, please.
Oh, so sorry, just 2 reflections on the what's wrong with you. I wanted to just share with folks a few examples of like what that actually looks like in our day-to-day work. So the what's wrong with you sounds like, oh, well, these clients are hard to reach, right? That's what it sounds like. Us deeming these clients as hard to reach. Another example of what it sounds like, oh, well, this client didn't take their medication. Why didn't they finish their hepatitis treatment, right? It sounds like us always putting the onus on that client, right? Of what's wrong with them. Why is this community so hard to reach? Why are they not following the instructions of the treatment plan that we created for them? And I want to invite folks to also think for the second part of what happened to you. There's just a reflection that the medical director out of University of California, San Francisco's Women's HIV program, Dr. Eddie, who's very much like an evangelist for trauma-informed care, shared. And he said that once years ago, when the clinic decided to, take the steps to become a trauma-informed care clinic and educate themselves, the staff, he no longer asked himself why he had clients coming in yelling at him and being upset about XYZ, because it demystified why this was happening, right? When he would learn what their stories, what their experiences were, everything that happened to them before they walked into the women's HIV program at UCSF, it demystified. And so he said, I no longer wonder why, they might be yelling at me, or why they might be really upset one day, or why they might not say one word during the entire care appointment. I no longer wonder, because I know what's happened to them. And for the folks who haven't disclosed their full story yet, I can suspect what has happened to them. And so I just want to share that, those 2 examples with folks.
I love that. Yeah. And, it's from a service provider perspective, even thinking about, like you were saying, oh, I'm going to forget, kind of even before, so there are 2 sides to this, right? Because there's so much stigma around people who use drugs. And there is so much stigma that assumes that people don't give a shit about their health. They just don't care. That assumes that they can't be adherent to medication. And so service providers are often very hesitant, if they're even legally allowed to offer like hepatitis C medication or treatment regimens to people who are in active use. That there are a couple things that we just see the need to address that stigma and really make sure that service providers do know that people who use drugs are actually evidence-backed, just as adherent and able to be as adherent as folks who are not using drugs. And that also, that might not be that might not be on their top 10 in terms of laundry list of what they need to get done and what they need feel healthy and safe and well, right? And so really meeting people where they're at. I know that that's, you know, kind of harm reduction cliche at this point, gimme, but it's real, so real. You know, there's just so much that goes into what's going on for someone every day. I mean, I think about my days. My days are hard too. You know, there's a lot going on. If, you know, trying to prioritize for a participant is what I'll say is never going to really be very effective. In fact, it's just going to make them feel very, very judged, stigmatized. You're going to be part of the problem here, right? Which is actually kind of where we wanted to go into some of this conversation. It's sort of like, what is it that we can do in our organizations to make ourselves more trauma informed, but also like at the systems level and policy level, like what are the ways that we need to acknowledge that we create systems that are traumatizing and historically have, and how do we envision a world where we could make that better, right? You know, when I think of harm reduction, I think the easiest way for me to describe why harm reduction is effective and why it was created, why it came about, is to have a community of people who are so deeply marginalized and stigmatized and alienated, made to feel awful, even engaging in traditional or mainstream medical care, that they said, no, there's got to be a better way. And they created a whole alternative version of medical care for themselves that is community-led. Community-led. And I think that that's one of the things that also, you know, really comes back to that idea of one of the most vital ways that, well, one of the many ways that people cope with trauma is about having control and about being proactive and doing a thing. And so community-led naloxone distribution and overdose response, community-led programs, hearing from those folks this morning who were talking about, like, you know, I created this program because that's my history, that's my past. I wanted to give back to this community, right? That is empowering, and empowerment leads to resilience, right? And so I think that that's a really important point to be making here as well. So yes, I mean, obviously we're talking about trauma-informed care, thinking about adaptation, adaptation kind of regardless of what that is in terms of the protective factors or the ways that you find to cope, whatever works for you, that really highlights adaptation and resilience, right? And we, like, over pathology, and we know pathologizing, that is like the word for people who use drugs, and we need to get rid of that stuff. Like the language, the stigma, like there are so many ways that, like, we can do that on a personal level, we need to do it at an organizational level, but we need to do it in the community level too. And I always like challenge people, because when you go out in community, you hear people say awful things about people who use drugs, calling them addicts, using wrong language, you know, like those people, that kind of thing. Call people out. Please just call people out. Ask them, or call them in, right? Ask them, right? Kind of challenge, push back on some of those things. I know that I've had to do that so many times, both in my community and my family. And I just, you know, that is a walking orders I would give to anyone who's present doing this work. Let's go to the next slide. Yes, call them in, thank you. Yes. So this is the part that, you know, I know we have about 15 minutes left or so, and I know Mahala and I can talk kind of all day, but we were hopeful, hopefully, that we could get some feedback from you all, right? Are there ways that your organization or where you work, or, you know, where you are coming from, that you've seen are really doing good trauma-informed work, right? Or might need substantial improvement? Thinking about staff or workforce. I know we're kind of out of time. I wanted to go through these like kind of one by one, but if you have responses to any of these, please feel free to chat them in, because I know that we'd love to hear more, right? So thinking about, like, if you're working in a program or even in a health department, thinking about what mental health supports and extra supports need to be available for you or your folks to meaningfully support your workforce. And then also kind of a question and a plug, I guess, for us is like, what do you need to think about meaningfully incorporating trauma-informed approaches at your organization? Because that's actually kind of where NASTAD like lives, is in this, like, we build resources, we help reflect on systems and help build, provide technical assistance on a variety of different things. So if there are things that would be helpful, we want to hear, Mahala, do you have any thoughts or comments while we're hearing more?
Yeah, I was actually just going to reflect on Catherine's comment in the chat. First of all, thank you, Catherine, for your transparency in sharing that. And peer support, as you probably saw earlier, is actually one of the trauma-informed, SAMHSA's trauma-informed principles, one of the 6. As well, it was reflected in the harm reduction principles. So it is certainly one of the, I would say, arguably, probably one of the most powerful principles to taking a trauma-informed approach. So thank you for naming how that has been supportive to you in your healing journey as well. As folks are chiming in, I actually appreciate Catherine's sharing, because one of the other things that I wanted to mention is related to the 6 principles. So for time's sake, we kind of like didn't go too much into how do you kind of how do we incorporate these principles into our day-to-day work? So I think Catherine's example is one of a peer support group. So as folks are chiming in on the chat, I can share another example or two from the 6 principles that might be helpful to you all in your work, because I certainly want you all to walk away with approaches. So for peer support groups, that obviously do not just include, people who are living with HIV or hepatitis or people who use drugs, but are also facilitated by folks who maybe are actively using drugs or in the past have used drugs. That is an extremely powerful approach to the work that we do, specifically around collaboration and mutuality, right? That's one of the 6 principles. Trauma survivors likely have experienced a loss of power related to that trauma, right? And so an approach that seeks to equalize the power differences can restore agency to that survivor and to really help them in taking ownership of their care and treatment services, right? The experience that they have. So allowing them to collaborate with their providers, that is incredibly powerful. Shared decision-making. So a provider not taking on the development of the treatment plan completely by themselves, but maybe framing it in a way of like, hey, what are your goals for your treatment and for your time here? And then collaborating and letting really that individual lead the conversation about what would be helpful to them in order to achieve the outcomes that they have carved out for themselves. I know that can be challenging because sometimes we have certain deliverables that we need to meet on our end, but as much as you can, really being flexible in that area, and pushing back a little bit when the opportunity presents itself to your funders, if they're not creating a structure for your funding that allows you to do that. So I'll just give one other example. So that was collaboration, mutuality, trustworthiness and transparency. Trust is something that is usually compromised, again, right, in that experience of trauma. So working to restore trust with survivors by being transparent as possible. If you are not able to do something because of the powers that be, because of your funding structure, whatever that is, being transparent so that folks know that you're not just acting as a barrier or a gatekeeper just because, right, of malintent, that in and of itself is incredibly powerful, right? So people living with HIV should be given the behind the scenes information, right? We should explain why these decisions are made. And on that same, same page, but maybe the page across, how about that? People living with HIV and staff should also receive warnings when there can be content or activities that could be triggering, right? Again, that might not seem like something when we first think of it logically, like how does that relate back? to trustworthiness or transparency, but it does, right? You want a person to feel like this is a safe space when they walk into, your exam room, or when they walk to access syringes that you may be distributing.
Or even just, nobody's perfect, right? Like, we're going to accidentally trigger and cause trauma, but like actively, the point here is like creating an environment where you are seeking it to the best extent possible to not actively re-trigger. Even having the conversation about like you were just saying, kind of better understanding when and why folks, like what their triggers are, even if I know I'm going to mess up on that, right? Just the awareness that that person actually cares and is trying to hold that in their interactions with me as a participant, right, is valuable, really, really valuable, because we all are going to mess up, or make mistakes here. Oh damn, what was the other one that you just said? Just the way that you were just kind of explaining those things through, right? Really thinking about just how closely that mirrors to harm reduction, right? Just how closely, like thinking about mutual support, thinking about participant involvement, thinking about, yes, Erica, thank you, to this conversation, this relationship with the best of intentions, and the real transparency that there are things that might not be possible. Right. And I also will say, I agree, pushing back in terms of funding, if possible, when possible. So much of, I feel like, the work that NASTAD and our drug user health team has done in the last many years has actually, one part of it has been kind of serving as like a bridge between funders like the CDC folks and programs, right? Like, we provide technical assistance to programs all across the country in a variety of different ways. And we're a little closer in relationship. So we've really been trying to make this, case and really build support for, just a real complex and comprehensive, like, really shaping what comprehensive care for people who use drugs really looks like. Because right now, for those of you who work in health departments, right now we have this whole range, spectrum of services that people might want, might need. We could couch in SSPs, hopefully we do, but they all come from with different funding streams and with different metrics and that sort of thing. And so the more we're trying to push away this, from this dialogue of, just numbers of HIV tests and numbers of, virally suppressed and numbers of syringes in and out, all of that, like, let's start talking about like what general support people need, and trying to build this case for just how complicated people's lives are, and that's okay. In order to work with someone effectively, anyone, whether they use drugs, have HIV experience, or risk for that or not, is to really understand that context and the environment and what that person's, priorities are. Vitally, vitally important. Yes, I appreciate all this conversation in the chat box. We aren't perfect. We do come from a place of love. And I think in a couple minutes, I know that we have to go back to the, go on break in the other thing, but a couple points that I did kind of like jot down and just wanted to like really touch base on, especially, it's thinking about some of the ways, again, that some of our systems and our programs maybe are designed and to create harm, or intentionally or unintentionally, right? So thinking about overdose response programs is probably one of the better examples, I think, there, right? Like, there's a push in many states and jurisdictions, communities, to really be putting, the naloxone in the hands of law enforcement, right? And recognizing full well that people who use drugs probably have a greater likelihood to have come in contact and negative contact with law enforcement, probably very wary around that. And so the idea that if your community is doing that and limited in scope, the impacts that might have in terms of being traumatizing and triggering for someone who is, overdose is already triggering enough, and then waking up to cops. It really, like, so being thoughtful about who we're putting, who we're giving naloxone to, who's going to be the best messenger, who's going to be the most appropriate, most effective in terms of minimizing potential harms, right? How we're prioritizing those things. And then also this idea about the thing that harm reduction really does well is about reducing the paternalism embedded deeply in mainstream medical care, right? Like democratizing it somehow. And, you know, and I think that as service providers, it's really important, like Mahalit was saying, to be minimizing all the barriers and the power structures and the hierarchies to whatever extent you can, as much as possible, because we know that that is really, I mean, you know, just the paternalism in terms of, you know, that can come in the place of judgment, of asking too many questions, too personal questions, questions that don't matter, they're not relevant. All of that stuff is potentially traumatizing and triggering. And there are so many ways that we can be more thoughtful in how we create and implement programs and support programs to be more aligned with trauma-informed approaches. So I'll pause there. So I recognize that we only have about 5 minutes left, 3 minutes left. And that makes me sad. And honestly, I wish that we could have this conversation as more of like in a smaller group kind of way, because I really think there's such value to working through these things as an organization, as individuals. There's a lot to through here, right? Break down here. If you want to go to the next slide, I think it just has our contact information. Oh, Mahalit, you want to touch on this, and then we can kind of close out for this.
Yes, I forgot that I snuck this in at the last minute, Laura.
I didn't look clearly.
I just, I know we were not, or we suspected that we would not be able to get through everything we wanted to today. So I just wanted to leave you all with some sort of resource, right? I think we were able to talk a little bit about the background, right? The science and the foundation, and then even start talking a little bit about the approaches that we can be taking, or just at least things to be mindful of as we do this work. So the Trauma-Informed Approaches Toolkit is available on NASTAD's website, and it does a bit of a deeper dive. Also, I know there were a few comments of folks that appreciated like that background and the science behind it. It does a much deeper dive. The toolkit does a much deeper dive of what we discussed on that part today. So I just want to encourage folks, if you go onto our website, you can easily find the Trauma-Informed Approaches Toolkit. I want to encourage you all to use that as a resource. But yes, that is it, Laura, for me.
It's a really amazing resource. And while we're talking about resources, so we certainly have a variety of different cooperative agreements that our drug user health work is funded under to provide different types of technical assistance, both for programs on the ground, for health departments supporting programs. We'll really never say no, it's all great. So this is Mahalit makes fun of me because I never wonder why I never have time, downtime, but we are funded by the CDC to provide technical assistance directly to programs and people who are thinking about starting up programs, wanting to do that with the National Harm Reduction TA Center. You can email us, me. There is also a TA request mechanism that's on our website. You know, we're here for you, and you know, so we'll obviously like excited to be able to kind of usher that in. Again, this is one of the first times the CDC has ever given up some of that paternalism deeply embedded in the way that this is the first time that programs on the ground can request technical assistance, not through a public health system. And I just like, I want to, maybe that's like an interesting sort of takeaway from this, right? Is like, again, sort of like leveling and removing some of those power structures and hierarchies. I feel like, you know, we're in a different place with support for syringe access programs across the country. And so really excited to be able to offer that as a resource. And obviously, just so appreciative of everyone's work and support of syringe access in the South. If you were part of the panel this morning, you know, and you'd know because you're in the South, I'm in the South, we're in the South, that none of this is easy. This is really tough work. And so, you know, when I am doing these things, I'm like terrible because I always tear up a little bit, you know, but like it is deeply appreciated, you know? So, yeah, I hope that this was really helpful. Feel free to send us feedback or questions, any of that moving forward. And I will do the MC thing and say we're going to take a 15-minute break. And at the quarter hour, 15, some of you are in Central, some are in East, We will reconvene in the other link, the Zoom link over there, for the last session. You should not miss this one, anti-racism and harm reduction. It's gonna be awesome. So yeah, really appreciate you all and hope that you have a lovely afternoon and can make the next session. And yeah, it's been a pleasure sharing space. So thank you. And thanks, Mahalit. This is great.
Thank you.